evening, dear doctors and honorable guests. I am Ahmad Saleh, Product Manager, Pharco Pharmaceutical Industry, and we are together witnessing the opening of the virtual international conference in Egypt sponsored by Pharco Pharmaceutical Industry. And now we will start the scientific day, but before starting for our scientific day, we must thank big thanks to our dearest Professor Ahmad Assaf, who donated his time and effort to organize and supervise this specific scientific day. Thank you again, Professor Ahmad Assaf, and now we start the scientific day.
Thank you very much, Dr. Ahmed. Can you hear me?
Yes, I hear you. Yes, I hear you, Dan. Okay.
Great. Okay. So first of all, I would like to thank Pharco company for hosting this webinar. And I'm very glad to be here with you for this talk about the different strategies for the management of lens subluxation. It's rather a very tough subject and interesting at the same time. My name is Ahmed Assaf, Professor of Ophthalmology of Ain Shams University and Fellow of the Royal College of Surgeons of Edinburgh. Now I will start my talk because this talk needs a tremendous amount of time. So I will divide the talk into two parts. The first part, I will give you an overview and management of the lens subluxation. And then we'll open for questions for a few minutes, and then we'll proceed for the second part of the presentation, which is the case presentation for different grades of lens subluxation. We will show some videos how to manage different types of lens subluxation, and then we'll open again for questions and answers from your side before conclusion of this session. So now let's start the first part of the presentation. As you know, that lens subluxation can be classified according to the severity into mild, moderate, and severe. Mild lens subluxation means that there is zonular damage extent of less than 3 clock hours or less than 90 degrees of arc. For moderate lens subluxation, the damage of the zonules extend beyond the 3 clock hours but less than 6 clock hours, or in the range between 90 to 180 degrees of arc. And you can see in the cases of mild or moderate lens subluxation, there are some decentration of the lens towards the area of healthy zonules. Away from the area of weak or ruptured zonules. In cases of severe lens subluxation, the damage of the zonule extend beyond the 6 clock hours or more than 180 degrees, and the lens equator might be visible across the pupil even without dilation of the pupil, and sometimes in severe cases you can see the crystalline lens or the cataractus lens dangling into the anterior vitreous. So this is according to the severity, and you can see diagnosis of moderate and severe lens subluxation can be easily during slit lamp examination before the surgery, but sometimes examination or detection of mild lens subluxation might be very tricky because the lens looks like the normal lens or the normal cataract. So it's very important to predict and to detect mild lens subluxation or during slit lamp examination before the surgery in order to be prepared for the consequences of lens subluxation during phacoemulsification. So how to detect, or maybe to just highlight the suspicious in your mind might be lens subluxation in a case. First of all, you might see a tremulous iris on slit lamp examination, which is not always present in cases of mild lens subluxation. Of course, you should suspect lens subluxation if the patient has history of trauma in the same eye, or suspect lens subluxation if the patient or the eye has been operated before for glaucoma or posterior segment surgeries, because these surgeries, filtering procedure and posterior segment surgeries, might induce clinical damage of the zonules. Of course, surgeons should be aware by the systemic manifestations of other syndromes associated with lens subluxation, like Marfan syndrome, homocystinuria, Weil-Marshalzani syndrome, etc. These systemic findings might provide a clue for the surgeon that this patient or this eye might have lens subluxation. Of course, we should suspect lens subluxation if the patient had already subluxation in the other eye, as you can see in this photo. This one patient of mine, the left eye, you can see here, there is a massive lens subluxation. I told the patient, okay, this is the case. This is the difficult case, okay, but this is rather a straightforward case. And surprisingly, I found the lens subluxation in the other eye, which looks normal, the right eye, which looks normal, as you can see in the photo, but I found mild lens subluxation in this eye as well. So suspect lens subluxation if there is other eye already had lens subluxation visible during slit lamp examination. And the most important here is to look at the biometry. Please look at the biometry and suspect lens subluxation in an eye with a relatively long axial lens. I mean by relatively long axial lens beyond 25 millimeters. So if you found an eye with an axial lens beyond 25 millimeter, and at the same time, there is a shallow anterior chamber, so raise your suspicions that this might have a lens subluxation, even if it is not detectable on slit lamp examination. It might be detectable intraoperatively. So in any case, if you find an axial lens beyond 25 millimeters, at the same time, we have a shallow anterior chamber in the range between 2.5, 2.6, 2.7 millimeters. So suspect that this eye might have lens subluxation. What about intraoperatively? Sometimes intraoperatively, you can have a clue that you are going to have a troubles. As you can see in this movie, I found difficulty to puncture the anterior capsule to initiate capsular excess. I used to puncture the anterior capsule with Oturata forceps, and if you can see here that I couldn't puncture the anterior capsule. After several times, I succeeded, of course, but we found that the capsule is redundant or somehow elastic. And this is denoted by the corrugation here of the anterior capsule. This corrugation is a very ominous sign that we have a lens subluxation, or maybe one of the surest signs that we have a lens subluxation in this eye in particular, because there is no enough tension from the zonules at the equator of the lens on the anterior capsule. So you can find that the lens capsule is a little bit elastic, flaccid, redundant, cannot be punctured easily, and even the behavior of the capsule while doing the rexes is somehow abnormal. So once you find those corrugation of the anterior capsule during puncture of the anterior capsule, make sure that this lens is lens subluxation, and you should prepare yourself for troubles. Again, if you find during rexus formation, if you find a visible area of the lens equator, you can see here in this, you can see that the lens equator here is visible. It's visible in this quadrant, but it's not visible any other where. It's only visible here, but not elsewhere. So this lens equator is visible because the lens is already decentered toward the left side. Why the lens is decentered toward the left side? Because there is a lens or subluxation, or because of there is damage of the zonules in this quadrant in particular. And you can find here, while I'm doing the hydrodissection, you find that some abnormal mobility of the lens denoting or detecting the lens subluxation, confirming the lens subluxation, sorry. So these are clues, preoperative and intraoperative clues to detect lens subluxation, especially the mild lens subluxation. As I mentioned before, moderate and severe lens subluxation can be easily detected, and there is no problem with that. So now, what about the tools? You should prepare yourself. Once you have a lens subluxation, you should prepare yourself for this battle. This is not a routine cataract surgery. This cataract surgery requires an extra maneuvers, extra tools to avoid complications. So we have two categories of tools for lens subluxation. First, broadly speaking, we have the capsule supporting device here, and we have on the other side the equator supporting device. The capsule supporting device means that these devices act as an artificial zonules and should be placed prior to phacoemulsification, prior to cataract removal, to support and suspend the lens capsule during phacoemulsification and to avoid further damage of the lens of the zonules during phacoemulsification. Further damage of the lens zonule can come from increased intraocular pressure because of the irrigating fluid or the bottle height will induce pressure inside the globe, and this will cause tension on the zonules and may cause iatrogenic damage to the zonules already weak or already damaged. So you need something to support the lens capsule, and this is the capsular supporting device. And as you can see in the photo, they are actually hooks. There are hooks designed to support the lens capsule, and you can see here that the hook is blunted, so will be gentle on the lens capsule, especially in the fornix area, to avoid damage of the lens capsule. If you don't have access of these devices in your country, you can use the iris hooks. So you can use the capsular support system dedicated for the lens capsule, or if you don't have access to those devices, no problem at all. You can use the iris hooks, but the iris hooks in this way, you should bypass the pupil border and just overlap the rexis to suspend the lens capsule with the iris hooks. So this one category of devices, and the timing of implantation of these devices is very important, just after rexis formation, before cataract removal or before phacoemulsification. For the equator supporting devices here, and you can see which are known traditionally as the capsule tension rings. We have different designs for capsule tension rings. We have the standard form, as you know. You can see those devices. I'm pretty sure that you are very familiar with those devices. And we have the scleral fixation capsule tension rings that they are designed to fix to the sclera, to be fixed to the sclera. This capsule tension rings designed to fix to the sclera have an eyelet here. It eyelet maybe in the left side, sometimes in the right side, sometimes on both sides if you need extra support. And this eyelet is designed to pass through it Prolene 90 to be fixed to the sclera or Gore-Tex suture. And we have, similar to those devices, a segment just portion of the capsule tension ring. It's called capsule tension segment, and had the same function. It's equator supporting device, but provide localized support and fix the capsule to the sclera in a specific area. We have, again here, this is another standard form of the capsule tension ring, which is called the Henderson form. I will talk to you about it in a moment. It's similar in the function to the standard capsule tension ring. So, broad speaking, now we have the capsule supporting device. We have either the tools for the lens subluxation might be the capsule supporting device or the equator supporting device. The capsule supporting device, they are hooks, while the equator supporting device, they are rings or segments. So now we need to know the mechanics of the capsule tension rings to understand its value and its contraindication at the same time. Does it has contraindication? Yes, it has contraindication. So you should be aware of this. So the mechanics of the capsule tension ring acts by redistribution of the tension across the lens equator in 360 degrees. So if you have an area of miszonule, it will redistribute the tension all around 360 degrees and provide stability of the lens capsule during phacoemulsification. However, these rings cannot be used in cases of capsular tears. If you have a capsular tear, even a tiny capsular tear in the anterior capsule or the posterior capsule, these devices will cause tension on those tears, and the tear will extend, so will complicate the surgery even more. So please do not implant those devices as long as you have minor tears in the anterior or posterior capsule. On the other hand, we have the capsule tension segment, which is different from the capsule tension ring that we have only segment. That's why this segment is spanning in 120 degrees, and this segment provides localized transversal support to a specific part where the segment has been put. So if you put a segment here, it will provide support to this area only. If you need another support here, you can implant another segment here, or you can implant another segment here, as many as you want. Or you can even combine this segment with the capsule tension ring. So the segment here can provide localized support to the lens capsule in a specific area. And the beauty of this segment is that it's easier for manipulation compared to the capsule tension ring, and because it's of small size, and again, can be implanted in cases of the anterior or posterior capsule tear. So if you have a minor tear, there is no harm to implant this capsule tension segment compared to the capsule tension ring. So bottom line, do not implant the capsule tension rings in cases of anterior or posterior capsular tear, even if it is very tiny or small, but rather than you should opt to implant the capsule tension segment. When we should put the capsule tension ring? Well, I will say you two contradictory words. As soon as you need to plant these rings, but delay it as long as possible. So as soon as you need these lenses, once you find that it's not safe anymore to continue phacoemulsification without the capsule tension ring, you should implant the capsule tension ring. And try as much as you can to delay the implantation of these rings, because these rings, if implanted before phacoemulsification, we have two issues. First, according to the literature and according to my personal experience, it increased the risk of further damage of the zonules. So if you implant these rings in the presence of cataract, you might induce more iatrogenic zonular damage. It's not 100% in all cases, but you increase the incidence of iatrogenic zonular damage. Again, removal of the cataract after implanting this, removal of the cortex, sorry, after implantation of these rings might be quite difficult, because the cortex will be entrapped between the ring, PMA, and the lens capsule. So try to delay the implantation of these rings. Ideally, should be implanted prior to IOL implantation, just after cataract removal and after cortex removal. This is the ideal timing to implant the capsule tension ring prior to IOL implantation. But if you find it's not safe anymore to continue, you should implant the capsule tension ring at any time. We have here the variant of the standard or capsule tension ring. We have the Henderson capsule tension ring, which has 8 indentations. You see that this is indentation 1, 2, 3, 4, 5, 6, 7, 8, 8 indentation, inward indentation. So to provide some space between the ring and the capsule, this space can help the surgeon to remove the cortex easily compared to the standard ring. So if you are not safe anymore to continue phacoemulsification and you need to implant the ring, if you have the choice between the standard ring and the Henderson ring, of course, you should go for the Henderson ring, because Henderson ring won't make cortical cleanup difficult. It will be just as a standard phacoemulsification. So what about the general rules of capsule tension rings? First of all, standard rings is not suitable for severe decentration. Severe decentration or severe lens subluxation, you should use the scleral fixation capsule tension ring. You have to choose the capsule tension ring size. The capsule tension rings, by the way, comes in different sizes. Some companies produce the capsule tension ring in small, moderate, and medium size. So in this way, you should choose the size of the capsule tension ring based on the size of the capsular bag, and the size of the capsular bag can be predicted by the axial length and white to white. Practically speaking, sometimes you don't have the measurement of white to white in some cases. So practically speaking, if you just overlook the white to white and you need just to implant the ring, choose the medium and large size ring. Avoid small size rings except in pediatric patients, but you should use the medium and large size ring, even if there is overlaps of the two eyelids together. it's preferable that these two islets will be overlapped within the lens capsule to provide the maximum support. The disadvantage of using a relatively large capsule tension ring that sometimes implantation might be more challenging and more difficult, but it's preferable to use the larger size capsule tension ring in comparison to the smaller size one, because the larger size provide better and maximum support to the lens capsule. So, and don't implant, of course, the capsule tension ring in cases of anterior or posterior capsular tear, and this we can use the capsule tension segment instead, or you may opt to remove the whole lens capsule and try to implant the lens with other techniques like the intrascleral haptic fixation technique or suture to the iris, as you will see in the second part of this presentation. So, surgical management, how now we can go into surgery. Now we know the capsule tension rings, we know the capsule supporting devices, and now we know the rules of the capsule tension rings, and we know what about the timing of the implantation. How can we manage now the lens subluxation or the cataract associated with lens subluxation? You should, as a rule of thumb, keep or remove the lens capsule. You should ask yourself, should I keep or should I remove the lens capsule? Keep the lens capsule in cases of traumatic cataract or traumatic lens subluxation. Remove in cases of progressive zonulopathies like Marfan syndrome, for example. So, or in cases of severe lens subluxation cannot be managed, or you cannot save the lens capsule anymore. So, try to keep the lens capsule as long as it's just due to traumatic cataract, it's not due to a progressive zonulopathy. If the case of lens subluxation is due to progressive zonulopathies, even if it's mild case, it will be moderate after a few years, it will be severe after 5 or 10 years. And if you implant the lens this way and you kept the lens capsule and still there is a pathology in the lens zonule, you might find that the lens capsule complex drop down into the posterior segment of the eye after a few years. So as a rule of thumb, this is my personal preference, is to remove the lens capsule in cases of progressive zonulopathies and try to implant the IOLs in other ways, in like the scleral fixation or the suturing to the iris. And just keep the lens capsule if you have traumatic lens subluxation. So this is my personal decision tree. This is the last slide for this part of the presentation, and just pay an attention here, because this is my personal decision tree for management of lens subluxation. Ask yourself, is this a progressive zonulopathy or not? For example, Marfan, homocystinuria, they are progressive zonulopathy. So if the case is progressive zonulopathy, remove the lens capsule. Yes, so remove the lens capsule. No, it is not a progressive zonulopathy, you can keep the lens capsule. If you decided to remove the capsule, so you have to implant the lens either fixed to the sclera, and this way you should use the 3-piece IOL, intrascleral haptic fixation, or iris fixation, just fixed to the iris, or you can just implant an anterior chamber lens into the anterior chamber. It's not a bad option anymore. It's okay, but although it's not preferable or not my first choice in these cases, but it's okay. You can implant the anterior chamber lens if you have no other option. So if you decided to remove the capsule, so you have to implant the lens either fixed to the sclera or into the anterior chamber, or just fixed to the iris. Fixed to the sclera, we have two techniques now worldwide, very common, the glued IOL technique and the Yamani technique. For the suturing or fixation to the iris, we have the 3-piece IOL sutured to the iris and stress on 3-piece IOL. You cannot suture the single-piece IOL, the acrylic single-piece IOL. You should suture the hydrophobic acrylic 3-piece IOL to the iris, or we have the PMMA lenses that is known as the iris claw lens. You can just fix it to the iris either in the anterior chamber or in the retropupillary plane. So let me remind you again, if you find that this is a case of progressive zonulopathy, you should remove the lens capsule and try to fix the IOL either into the sclera by glued IOL technique or the Yamani technique, or just implant the lens into the anterior chamber. This is the least option in my mind. Or you can fix the IOL to the iris with a 3-piece IOL to the suture to the iris, or use the iris glow lens. Now, if you decided to keep the lens capsule, we have now to differentiate between mild or moderate or severe lens capsule decentration or subluxated cataract. In mild cases, you can implant the standard CTR, the standard capsule tension ring, or my preferred technique is to implant a 3-piece IOL. As long as this is a mild decentration, you can still implant a 3-piece IOL into the sulcus and do the optic capture without the use of the capsule tension ring. So this is the two options if you have a mild lens subluxation and you decided to keep the lens capsule. In moderate cases, you can implant a scleral fixation capsule tension ring, because if you implanted the standard capsule tension ring, you might end with a lens tilt. It's better now to fix the ring to the sclera, so you have to use the scleral fixation capsule tension ring, or you can use the capsule tension segment, 1 or 2, according to your preference or according to the situation. If you have a severe form of lens subluxation, we have 3 options. First, you can use the scleral fixation capsule tension rings, and sometimes you need the double eyelet form to provide maximum support. Or if you don't have the access to the double eyelet form of the capsule tension ring, you can implant the scleral fixation capsule tension ring, and you can add extra capsule tension segment, and I will show you in a movie in a moment. Or if you are fed up, and this is a severe case of lens subluxation, and only few zonules are intact, and most of the zonules 360 degrees or maybe 355 degrees has been already torn or damaged, and you are fed up with this lens capsule, you can remove this lens capsule and treat it as the case of progressive zonulopathy. You can implant now the lens fixed to the sclera, fixed to the iris, or in the anterior chamber. Make sure that in any case, if you find or if you had a torn capsule, so you should opt to either implant capsule tension segment or remove the lens capsule and treat it as a progressive zonulopathy. So in any case here, if you decided to keep the lens capsule, but the surgery has been complicated by tear in the anterior or posterior capsule, even if it is a very small tear, you should now opt to capsule tension segment, or you can remove the lens capsule completely and implant the lens, fix it to the sclera or the iris or into the anterior chamber. Now I think I have finished my first part of the talk. We'll go for some questions from your side. I will see the questions already highlighted by you. I'm trying to answer as much as possible, as many as possible. Hello? Question, would you implant a routine capsule tension ring as in routine pediatric cataract? Well, I don't prefer to implant it as a routine, except if I have some lens laxity or capsule laxity or weak zonules, but it's not a routine in my practice. Marfan syndromes, we will use the capsule tension ring till finish phaco, then remove, or better don't use. This is a good question. A question asked about the Marfan syndrome. Can we use the capsule tension ring? Yes, you can use the capsule tension ring and remove it, but it's better to use the capsule supporting device, the hooks. The capsule supporting device, which act as an artificial zonules, is much better than the capsule tension ring. In this case, capsule tension ring will stretch the capsule, but it won't avoid tilt of the IOL or avoid tilt of the cataract during phacoemulsification. But if you suspend the lens capsule with the capsule supporting device, it will be a very good option to continue phacoemulsification safely. But anyway, I don't prefer to implant the capsule tension ring in Marfan syndrome, even it's I'm going to remove it, because removal of the capsule tension ring is already challenging in these cases. And decide, how can you decide it is mild, moderate, or severe lens subluxation? I think I have already answered this question. Probably you didn't attend the lecture from the very beginning. Mild lens subluxation, it's quite difficult to detect, but theoretically it's rupture of the zonules 3 to 3 clock hours, by moderate 3 to 6 clock hours, and severe more than 6 clock hours. Is pseudoexfoliation is a progressive zonulopathy? Yes, pseudoexfoliation is progressive zonulopathy, but it's a slowly progressive zonulopathy. It's very slowly progressive. So you can treat it as a traumatic cataract. You can preserve the lens capsule and implant capsule tension ring, but you should keep an eye on these patients. You should follow up these patients annually at least to make sure that the lens capsule are still in place. And if there is any future decentration, you can just fix the lens capsule to the sclera. Yeah, another question. Do you consider pseudoexfoliation as a progressive zonulopathy? Yes, I consider it as progressive zonulopathy, although it's not as progressive as the Marfan syndrome. It is progressive zonulopathy. I prefer to remove the lens capsule, but if the pseudoexfoliation at the time of the surgery, the lens is in place and there is no sign of lens subluxation, I can keep the lens capsule and do routine phacoemulsification, implant the CTR, implant the lens, and keep an eye on these patients. You should examine these patients annually, as I mentioned before. CTR in toric IOL in myopia, yes, is a good question. We can implant the CTR to prevent, to stretch the capsule and minimize rotation of the toric IOL, especially in high cases or high myopia because of the large lens capsule. However, this is beyond the scope of the presentation nowadays. Dr. Nancy, would you suspend the capsule in cases of weak zonule using sutures if CTRs are not available? Yes, we can do it, although it's a bit challenging, but we can do it. Yes, we can suspend the zonules with the 9-prolene, 9-O-prolene or 10-O-prolene. It's preferable to, of course, 9-O-prolene because 10-O will fade up in the near future. How many clock hours subluxation to consider for mild, moderate, severe? I already asked this question, answered this question. Would you consider pseudoexfoliation as progressive zonulopathy? Again, I answered already this. Why CTR is not preferred in capsular tear? Okay, we have already answered this question because we'll extend the tear, because it will stretch on the capsule and will extend the tear and will complicate the surgery. We'll find that the lens, the capsule tension ring might fall into the posterior segment of the eye. What about the rule of extracapsular, intracapsular in such cases? We can, of course, do the intracapsular if you decided to remove the lens capsule. I will show in some movies here that I decided to do the intracapsular cataract extraction or extracapsular cataract extraction in some cases of lens subluxation. How to fix segmental CTR to the sclera? I will show you in a moment. Would you recommend CTR in post-trabeculectomy cases? Yes, and post-vitrectomy, I mentioned that those cases already had subclinical damage of the lens zonule. If the intraoperatively you find that the lens, the zonules are somehow damaged or they are not healthy anymore, you can add an extra support by CTR. But some eyes, you will find that the zonules are perfectly or completely healthy. There is nothing wrong with these zonules. So in these cases, I won't implant the CTR. So it's you according to your judgment. If you found that the zonules are somehow damaged because of the previous filtering surgery or the posterior segment surgery, of course you should implant the CTR. If not, you don't have to implant it and don't have to complicate the surgery and add extra steps. Okay, do you put CTR in toric IOLs as a routine? No, I don't put CTR in toric IOLs as a routine. I don't want to complicate my surgery and I don't want to add extra steps. I just do it in cases of high myopia sometimes, not every time. Okay. If the dehiscence is less than 3 clock hours, but inferiorly, Is it convenient to implant in the sulcus? Yes, you can implant in the sulcus. I will show you in a moment. You can implant in the sulcus as long as the dehiscence of the lens zonule is less than 3 clock hours. What is the right moment to implant the lens capsule tension ring? Too early and nucleus could remain, too late and we could have total luxation. Yes, I answered this. Is quite difficult to judge when should you put the CTR in each case. In every case should be individualized. If you find yourself able to continue phacoemulsification safely without implantation of the CTR, proceed. If you found it's not safe anyhow, you should implant the CTR. Implantation of the CTR in the very beginning or too early, as you mentioned, may induce more damage to the zonule and make cortical cleanup later on quite difficult. And it's better in this case to suspend the lens capsule with the iris hooks or the lens capsule supporting system. This is the function of the lens capsule supporting system. You should implant those hooks very early to support the capsule prior to phacoemulsification. Dr. Safwan, how are you? And are you using the Gore-Tex suture to the scleral fixation? Unfortunately, I don't have the Gore-Tex in my country, but if I have the Gore-Tex available in my hands, of course, I will do the Gore-Tex to suture the CTR to the sclera. Better Gore-Tex or nylon? I don't have experience with the Gore-Tex. You should compare Gore-Tex to Prolene, not nylon. So I use the Prolene 9.0 as long as it's available in my hands. But if I have the Gore-Tex available in my hands, I will definitely go for the Gore-Tex. How to explant CTR if it goes to the sulcus? It's you should. I cannot describe it except I should have some videos here. But you should try to introduce a Sinsky hook and attach it to the eyelet of the CTR and try to flex it and put it back into the lens capsule, or you should explant the capsule tension ring and try to implant it again in the lens capsule. So if the capsule tension ring didn't find its way correctly to the lens capsule and you find it in the sulcus, you'll get hard time, of course. Try to find the eyelet of this capsule tension ring and try to flex it towards the central area, and now try to remove it through the main incision and reimplant it again. So I think we should now continue to the next part of the presentation, and then we will open again for discussion. I'm sorry because time is running. So this part, I think this is a really interesting part of the presentation, and I hope the video, you will see the videos quite well. So this is the second part, which is a case presentations. This is my own cases, my own fallacies, my own complications. So I would like to share with you these cases and to learn, and of course I should learn as well from you, from your discussion, and from your questions. So let me remind you with the decision tree. This is a case of mild lens subluxation. Mild lens subluxation, and this is a case was not because of progressive zonulopathy. So I decided to keep the lens capsule with mild lens subluxation. So I have two options here. This is a case that's traumatic. It's not a progressive zonulopathy, mild. Okay, so I have two options here: either to implant the CTR, the standard CTR, or to implant the three-piece IOL in the sulcus without the CTR and just do the optic capture. This is the case of mild CTR. You can see here. This is the rexus, and you can see here. You can see look at this. Look at this corrugation. You can see abnormal behavior. Now the rexus now has tendency to run out, so I have to inject more viscoelastic here to then before continuing rexus formation. This is one of the difficulties in cases of weak zonules. So I decided here now. I know that I have mild lens subluxation, although lens look pretty well centered. And this is the capsular supporting devices. This is very important. If you don't have access to those devices, you can implant the iris hooks. And then you continue phacoemulsification in the usual way. You can see here, I'm doing quick chop technique. This is my preferred technique, quick chop technique. And you can see I manipulate the nucleus within the lens capsule with ease without I'm very comfortable doing my routine technique in these cases, as long as I'm suspending the lens capsule with those artificial zonules. And again, please, before removal of the phaco tip, please never allow the anterior chamber to collapse, because it will stress on the zonule. So just inject OVDs before removal of the lens capsule. You can see that this is here. You can see here, this is the lens subluxation. It's about 2 to 3 clock hours here. This is the area where the lens subluxation. So as you can see, I can continue phacoemulsification. I can continue cortical cleanup without any issues, as long as I'm suspending the lens capsule with those wonderful devices. This is the lens capsule supporting system, or the capsular hooks. So this is the time for implantation of the lens. I don't implant here. In this case, I didn't implant the capsule tension ring. This is the 3-piece IOL, hydrophobic 3-piece IOL. I'm planning to implant this lens in the sulcus, so I should remove one of those hooks now to allow for the haptic to find its way to the sulcus. And as a rule of thumb, if you want to implant the lens in the sulcus, it's better to implant it in the anterior chamber in the very beginning. To just try to hit the lens, the anterior chamber, the lens into the anterior chamber, and then you can manipulate each haptic into the sulcus later on. So now the lens is already completely implanted inside the eye in the anterior chamber. Removal all of the hooks. Now, in this way, let me pause here. Here it is, the area of lens subluxation. So don't put the haptics one here and one here. No, put the haptics perpendicular to the area of subluxation. If you have subluxation here, so the haptics should be put this way. If the subluxation is here, so the haptics will be put here, up, and the other side. So this is the area of lens subluxation. So try to put the haptics here and here. And you can see here. Now I'm manipulating each haptic into the sulcus. And now this is the most important step. Do the optic capture. Press the optic of the lens within the rexes. As long as you have intact lenses, just press the optic of the lens into the rexes. You can see it now. This is the rexes edge. I hope you can see this. The rexes edge now has been turned into an elliptical in shape. It's cat's eye in shape, because now this is the lens optic here inside the capsular bag, while the haptics is already outside the capsular bag into the sulcus. So this is the lens optic, and you can see here that the lens has been beautifully centered without the use of the capsule tension segment. So in cases of mild lens subluxation, you still can use the 3-piece IOL in the sulcus while doing the optic capture. This is the case number 2, mild lens subluxation, and now this case has been already complicated by tear into the anterior capsule. This is a case of mild lens subluxation. You can see here, this is the part of the equator of the lens is already visible here. Again, once you recognize you have lens subluxation, please do the 4 paracentesis or 3 paracentesis, sometimes 5 or 6 paracentesis, according to the supports you need, and implant those wonderful devices, the capsular support system or the capsular hooks. Again, if you don't have access to those devices, you still can implant the iris hooks. But I prefer those devices because they are more gentle on the capsule, especially at the fornices, and they have broad ends. So you can see this is stromal hydration, and now I can rotate this huge nucleus. I'm doing my technique, preferred technique, quick chop technique. Again, there is no issues here. Quick chop technique, as long as I'm supporting the lens capsule. As you can see, I'm supporting the lens capsule in the area that I'm suspecting there is damage of the zonule. So here it is, you can see This is the area where there is damage of the zonules, so I can support here and here and here. I don't have to put a device here because it's already the zonule are intact. So I'm doing phacoemulsification. This is fast forward. And now this is the last quadrant. Again, please apply the rules here. Never allow the anterior chamber to collapse before pulling out of the phaco handpiece. And you can see here, this is some of the cortex has already been caught by one of the hooks. So I'm trying to free this cortical fibers here, but I failed. So I'll just remove these hooks and then continue irrigation aspiration. And then again, injection of dispersive OVD before pulling out of the phaco handpiece, and then removal of those wonderful device. And you can see here, this is here, now we have a complication here. Now we have a complication here. You can see here, this is the tear, a tear into the anterior capsule. Most probably I did the tear myself at the time while I'm trying to free some of the cortex underneath the lens capsule. So this is a tear in the anterior capsule. This is posed. Let's play it again for you. You can see this is the tear here. So nowadays, in this situation, I can't implant the capsule tension ring. Apply the rules. You have a tear. So I decided to either to implant CTS, capsule tension segment, or remove the lens capsule. So I decided to remove the lens capsule as a whole. So because I don't have access to capsule tension segment at this time, so I decided to remove the lens capsule. Now I have turned the eye to a completely aphakic eye. This is some cortex. I'm doing some manual aspiration of the cortex. Now the eye is completely aphakic. There is no capsule, there is no zonule, there is nothing. Jet black pupil. Now it's ready now for implantation of the lens. We have either to implant the lens fixed to the sclera, fixed to the iris, or into the anterior chamber. So I decided to fix it to the sclera with the Yamani technique. We have the glued IOL technique and we have the Yamani technique. So this is the Yamani technique. Maybe when in other talks we can stress on different methods for fixing the IOL to the sclera. This is loading the leading haptic into 28 gauge needle, and this is the other needle. So this technique is called double needle flange haptic technique. We should use two needles, 27 or 28 or 30 gauge needle if you have those kind of needles available in your region. I use the 28 gauge needle, and this is the trailing haptic. Now feeding the trailing haptic inside the lumen of the needle for a few millimeters, and now we should externalize both haptics. So might be this is the most tedious part of the surgery, trying to fix the trailing haptic into the lumen of the other needle. And the needle, you can see this needle already fixed to the sclera. Just leave it in place, and the other needle now already had the haptics, the trailing haptic. Now we should pull both needles, trying as much as you can simultaneously, or just one haptic can be externalized at a time, then you can externalize the other haptic. So I decided to externalize this haptic, and you can see now the lens find its way in the correct position centered to the pupil. Now this is one haptic here, already externalized. And to avoid slippage of the haptics, you should now fix the haptics with the McPherson forceps and remove the needle and apply the cautery, thermal cautery, to make the knob, and just release the needle. And do the same for the other haptic here. Okay, knob, release the haptic, and now push both haptics into the sclera, into the scleral canal under the conjunctiva, and you can see that the three-piece lens has already fixed in place with a decent amount of centration. And of course, I tried to make sure that there is no vitreous while maneuvering this lens. So I found some vitreous bands here, so I decided to do some anterior vitrectomy limbal approach, and I'd like to show you you can see how robust, how stable this lens is. I go behind the lens, I go in front of the lens with the vitrector, and the lens is still in place and is not susceptible to fall down into the posterior segment of the eye. So this is the beauty of this technique, very elegant technique. You can fix the haptics into the sclera, and still you have very well-centered lens and very robust lens in place. So this is case number 3. Moderate lens subluxation. So I decided to keep the lens capsule, go for the scheme here. Moderate lens subluxation, we have two options. We have the scleral fixation, CTR, or the capsule tension segment. This one of the cases that already misjudged. I judged this lens, or judged this eye as a mild lens subluxation. So this is my estimation at that time that this is a case of mild lens subluxation, but after implanting the lens and doing the optic capture, I found that the lens capsule are already decentered because of the massive or the considerable loss of the zonule in the inferior quadrant. So in this case, we can now add capsule tension segment. This is the capsule tension segment. You just feed the eyelet with a Prolene 9O here, and then you can implant here. Now you can implant. You can see that this is because of short arc length, it's easier to maneuver this segment inside the capsular bag. And now you can place 1, 2 according to the amount of support you need. So I just need one capsule tension segment. Dissect the conjunctiva, make some scleral grooves here, 1.5 or 2 millimeters from the limbus, and then externalize one of the needles here, one end of the Prolene suture here, and externalize the other end, few millimeters apart. Okay, this is externalize the other end, and then suture the both ends together. And now you can, with the tension you apply to the Prolene 9O, you can titrate the centration of the lens. This is another advantage of the capsule tension segment. Here you can titrate the centration of the lens, and then after you find that already the centration is okay with you, tie the knot and then bury the knot within the scleral grooves, close the conjunctiva, remove some cortex and viscoelastic, and conclude the surgery. So this is another case number 4, moderate lens subluxation, but it's further complicated by rupture or tear in the posterior capsule. This is a case here. This is already the lens has been implanted here, and you can see that there is it was an open posterior capsule, and you can find that after implantation, although the pupil is very small, that the lens and the capsule are tilted, evidenced by the optic edge of the IOL. You can see that the optics of the IOL is visible within the pupillary border. This means that the lens capsule are already decentered and tilted. So in this context of very small pupil, I have two options. I have to remove now the lens capsule. So my strategy is here to ignore the lens capsule, remove it, and we have to fix the lens either to the sclera or fix the lens to the iris, or remove the lens and implant an anterior chamber lens. So the best solution in my mind at that time is to keep the lens and just suture it to the sclera, to the iris. Suturing this lens to the sclera is my preferred technique, but in the context of this small pupil, things would be very challenging, at least to me. So I decided to suture the IOL to the iris. So it begins with prolapsing the optic into the anterior chamber while keeping the haptic in the sulcus, and then with a Prolene 10O, it's not a 9O, with a Prolene 10O, now you can suture each haptic to the iris. So this is the lens has already been prolapsed inside the anterior chamber, and now with a Prolene 10O, let me skip this part. Yes, this is the Prolene 10O. This is the haptic here is underneath the iris tissue, so pass through the sclera, the cornea, iris, under the haptic, iris, cornea again. And this technique is called modified Sipser slipping knot technique for fixation or intraocular suturing. And this is the other haptic again, cornea, iris, under the haptic, iris, cornea again. and then make a loop with the Coghlan hook. And of course, details of the technique is out of the scope of this presentation, but we can talk about the different techniques of fixing the IOL to the sclera or to the iris in another talk. But I'm going to give you the strategies of management of different grades of lens subluxation. So this is tying the knot here. I usually don't tie the knot very tight unless I'm sure that the pupil is rounded. So just make the knot a little bit loose on both sides. Now prolapse again the optic back to the posterior chamber of the eye and remove any iris tissue coat within the knots here, because if you didn't do so, you will end up with a peaked or cat's eye pupil. So remove any iris tissue coat in the knot until you have a rounded, perfectly rounded pupil again. So you can, at this time, you can now tie the knot and conclude the surgery. And I already removed the capsule, and this is through the sclerotomy. I removed the capsule because the strategy in this case is to remove the capsule, because I have already torn posterior capsule. I cannot depend on the capsule anymore. I cannot implant the capsule tension ring because already opened the posterior capsule. So although it was a moderate case, but because it was complicated with the tear in the posterior capsule, so I had to apply the strategy of removal of the lens capsule and depend on the iris or the sclera for fixation of the IOL. This is the case number 5, massive lens subluxation. It was traumatic. So it was here. This is not a progressive zonulopathy. It was, so I decided to keep the lens capsule, and it was massive or severe lens subluxation. So I have two options here: is to use the scleral CTR with double eyelet, or scleral fixation CTR with addition Ahmed segment. And this was my strategy in this case. You can see there's massive lens subluxation. Even puncture of the anterior capsule was very challenging. And this is again the beauty of those devices, that you can implant even before rexus formation to support the lens while doing capsular rexus. This is a hydrodissection and viscodissection. Luckily enough that the lens was not, the cataract was of the soft type, so with some vacuum I could aspirate the cataract, and you can see that the lens capsule is severely redundant. But since it was traumatic, so I decided to keep the lens and try to preserve the lens to implant a single piece IOL. So this is the capsule tension ring, the scleral fixation capsule tension ring. Feed the Prolene into the eyelids before introducing the ring inside the lens capsule. And now Ahmed segment again to add additional support. So I have a support in this quadrant, and I want another support by Ahmed segment, or the capsule tension segment, in the lower quadrant, and then implant a single piece lens. In this way, you can implant a single piece lens within the lens capsule. Again, you can titrate the centration of the lens capsule complex by the amount of tension applied to the Prolene suture. Case number 6, massive lens subluxation here, about massive or severe lens subluxation. And I decided in this way the lens was severely luxated. It was damage of the zonule here, bad visibility because of the bad cornea. It was a complicated cataract surgery for one of my colleagues and asked for help. So in this case, I decided to remove the whole capsule and treat it as progressive zonulopathy. So this is some remnant of the cataract into the anterior chamber. Again, here. And I decided here now to fix the IOL with the iris claw lens. Iris claw lens in the retropupillary area. Just invert the IOL, and these IOLs are designed, PMMA lenses are designed to be fixed to the iris. Okay. Let me plug the power of the computer. So this is another case number 7 here is massive lens subluxation and zonulopathy. In this case, because of the zonulopathy, I decided to remove the capsule here and remove the lens. So this is an example of intracapsular cataract extraction. I did a scleral incision, L-shaped scleral incision, because this incision is astigmatically neutral, and do some anterior vitrectomy, implant the 3-piece lens here, and I decided to do the glued IOL technique. Glued IOL technique to fix the IOL haptics to the sclera. And now, after sclera flaps formation, again, we can talk in more details about those techniques in another talk. So this is the strategy. Why? This is because of massive lens subluxation or severe lens subluxation, and it was progressive zonulopathy. So I decided now to remove the lens capsule and fix the IOL to the sclera by the glued IOL technique. Last case here is the neglected cataract with massive or severe lens subluxation. Again, here it is. You can, if you want to keep the lens capsule, sometimes if you find intraoperatively it's difficult to keep the lens capsule, you can even just remove the lens capsule and treat it as a progressive zonulopathy. Or in the very beginning, because it was neglected cataract for a long time, it was calcified, it was quite difficult to keep the lens capsule. As you can see, the lens capsule is already very redundant, and there is massive lens subluxation. I find no harm in capsule and implant the lens and employ the Yamani technique again to fix the IOL to the sclera. Again, one of the most important tricks here for the Yamani is to keep the IOL, to keep the globe inflated or pressurized. So you have to just insert anterior chamber maintainer of any type into the anterior chamber or in the posterior chamber if the eye is already vitrectomized. Because this technique, sometimes the eye is getting soft while maneuvering the lens in place. So it's better to stabilize and pressurize the lens with the anterior chamber maintainer. And now implanting after making the knobs of each haptics, now placing the haptics into the sclera and closure of the corneal wound with 2 stitches. So I'm open now for questions from your side. So does CTR affect the PCO incidence? I doubt this. Sometimes in the literature, it's proven to have a beneficial effect in reduction of the PCO, but I doubt this. Do you prefer try CTR or CTS in moderate severe lens zonular dehiscence, or you better go with removing of the bag and anterior vitrectomy and scleral fixation? In cases of mild and in cases of moderate to severe zonular dehiscence, according to the zonulopathy, the question is, in cases of moderate and severe, should I prefer CTS or CTR or remove the lens capsule? In these cases, according to the zonulopathy, if there is a progressive zonulopathy, I will definitely go to remove the lens capsule. If it's not, I can implant the CTR and or CTS. If I found that the surgery is complicated by tear in the anterior or posterior capsule in this way, I should remove again the lens capsule and fix the sclera, fix the IOL to the sclera. During surgery, maintain IOP stable during phacoemulsification. What the optimum time to remove the CT be implanted and not be removed. Removal is the capsule support system. Capsule support system should be removed prior to IOL implantation. The capsule support system, which traditionally known as the iris hooks, should be removed prior to IOL implantation. Should be placed in the very beginning before phacoemulsification, continue phacoemulsification, continue irrigation aspiration while the hooks are in place, and then you can at this time then you can remove the capsule support system and implant the CTR. But CTR are designed to be placed, not to remove. There is no timing to remove the CTR. Once you decided to place the CTR, you should keep it. A good question. In case of mild zonulopathy, can you implant three-piece IOL in the bag? Yes, we can, although it's not very preferred technique. And in this case, if you decided to implant the three-piece IOL in the bag in cases of mild, not severe or moderate, mild lens subluxation, you should put the haptic away, both haptics away from the, sorry, again, in the area of lens subluxation. One of the haptics should act as a capsule tension ring. You can put the haptics in the capsular bag, one of the haptics towards the area of zonular dehiscence to act as a lens, as a capsule tension ring. But if you decided to follow the technique that I like, which implant the lens in the sulcus, now in this way, you should put the haptics away from the area of the zonular dehiscence. So if you decided to put it inside the bag, put one haptics at or towards the area of zonular dehiscence to act as a lens capsule tension ring. Otherwise, if you decided to put it in the sulcus, you can put it away from the area of zonular dehiscence or rupture. In a progressive case, do you recommend removal of the bag even it's only mild? Yes, in progressive cases, because if it is mild lens subluxation at the time of the surgery, it won't be mild after a few years. It might turn to moderate to severe. So I prefer to remove the lens capsule even if it is progressive zonulopathy. In case number 1, can we put PMMA? The case that already I have shown you, yes, Dr. Hasna, we can implant the PMMA lens, of course. We can do it. We can do the PMMA in the sulcus, but optic capture would be quite difficult because the PMMA lens is uniplanar. The three-piece lens has the optic pushed backwards and the haptics migrate forward about 20 degrees. So it makes the optic capture easier because you are placing the haptics in the sulcus and the optic is pushed backwards, so it's easy to implant the optic within the lens capsule. But PMMA, it's a valid option. Of course, we can implant the PMMA lens in the sulcus. Try as much as you can to do the optic capture, but if it is failed, it's okay. You can just keep the lens, PMMA lens, in the sulcus. And of course, you should use the PMMA lens with the larger diameter, 13 millimeter or 13.5 millimeter would be preferable in those cases. How can you be sure that you can catch the haptic behind the iris? This is, I think, this is the question regards the suturing of the haptic of the three-piece lens to the iris. It's quite easy. Just try to elevate the optic of the lens and you will see the haptic already indent the iris. Once the haptic in the sulcus indent the iris, you can easily pass your needle behind the through the iris behind the optic. So try to indent. Maybe we can dedicate a session for these techniques. We can a session for suturing the IOL to the iris, another session for the scleral fixation Yamani, session for the glued IOL, etc. So I'm sorry because this is a very tough and large subject for 2 hours. What is the biggest size of the needle? It's a good question. For scleral fixation IOL, it's a very long needle, but exact size I have no idea. It's a good question. Maybe I will look for it next time I saw this needle. But actually, it should be a long needles, large needle and long, because too much inside the eye. How would you estimate the length of the haptic that you are going to cauterize? 1 or 1.5 millimeter. Just keep 1 or 1.5 millimeter from the tip of the haptic with the McPherson, and then you can cauterize this part. If you are going to cauterize 2 millimeter from one haptic in one side, you should cauterize 2 millimeter in the other haptic in the other side. Do you do peripheral iridectomy in cases of iris claw lens? No, I don't, although many surgeons do so. I don't do peripheral iridectomy because once you invert the IOL looks like this. It's already will be concave. So there is a void, or there is a potential, or there is already actual space between the iris and the lens. And I don't believe that the PI will add something in these cases. So it's a very good question. I don't do the peripheral iridectomy in cases of retropupillary iris claw lens. Uh, Please, can you upload the link to the lecture on YouTube? Yes, okay. I will upload the whole movies in my YouTube channel, Ahmed Assaf. You will search for it, and you will find the whole lecture and the whole movies. I will upload a lot of movies in the next few weeks. Do you do pars plana anterior vitrectomy? Of course, I do pars plana anterior vitrectomy once indicated. If there is a complication and vitreous loss, I do pars plana anterior vitrectomy. I prefer pars plana anterior vitrectomy in favor of the limbal approach. Dr. Islam Al Khouli asked about the position, the IOL affect the power or the post-operative refraction. Yes, it affects the post-operative refraction by a quarter of a diopter. So I don't think this is an issue in these complicated cases. It depends about how long the haptics inside the eye. If you are going to make the haptics short, the IOL will move forward and this will translate to myopic shift. If you keep the haptics as long as possible, most probably you will end up with the same refraction as if the IOL in the bag. The limits for lens subluxation that we cannot do phaco and shift to intracapsular cataract extraction. Of course, this is according to your judgment, but it should be individualized for each case. But as a rule of thumb, if you find that the lens subluxation beyond 6 millimeter, beyond 6 clock hours, this is a moderate lens subluxation, and you should now implant a CTR or CTS. So if you don't have access of those devices, of course, you should now remove the lens capsule and implant anterior chamber or iris claw lens or fix the IOL to the sclera. What do you do if aniridia and subluxated cataract? Very good question. Aniridia is very challenging. So in this case, I would do glued IOL technique and I will remove the lens capsule and I move the lens, whole lens, either by lensectomy or intracapsular cataract extraction and implant artificial iris. So I will just fix the IOL to the sclera. Another question, what makes you prefer one of scleral fixation technique over the other? Over the, for example, the iris tissue fixation or the IOL fixation or iris fixated IOL. As you know that fixing the IOL to the sclera provide a very good stability of the lens. And you have seen one of my movies that I was doing vitrectomy while the lens is fixed to the sclera and the lens didn't move while doing the vitrectomy, although I go behind the lens and above the lens. This is one factor. Other factor that the lens haptics goes for a certain amount into the scleral canal, and this provides better stability of the lens in the long post-operative period. For the iris suture IOLs, the IOL will be fixed to the iris, and there are some phacodonesis or some lenticulodonesis or IOL donesis in the post-operative. You will see that the lens is still moving by the tremulous iris while the patient moves his head or his eyes in one way or another. So this is one factor that I don't prefer the iris suture technique as a first choice. And the same applies, of course, for the iris claw lens. Again, in this the iris suture technique, you should use now Prolene 10O, and there are some questions about the long-term stability of these sutures after implanting the lens. About 10 years, maybe these sutures will fade up, and you find that the lens already dislocated in the posterior segment of the eye. So that's why I prefer the scleral fixation techniques, whether the glued IOL technique or the Yamani technique. If mild to moderate zonular dehiscence occurred at the end of the surgery, what to do? If mild, I will implant a 3-piece IOL. If moderate, I will add CTS. And I think I have shown this in my videos. Implant the lens or implant the CTS capsule tension segment and then implant the lens in the capsular bag. If mild, you can implant a 3-piece lens in the sulcus or just implant the regular capsule tension ring. When you use combined CTR and CTS, which direction or quadrant you should put CTS according to the area you want to support. The capsule tension ring, the scleral fixation. If you use the scleral fixation capsule tension ring, the maximum support will goes at the area where the eyelid is. Where the eyelid is present, this is the area of maximum support. If you need another support in somewhere else, you can put the capsule tension segment. But if you use just regular CTR and you need an extra support, you can judge where is the tilt according to the tilt of the lens capsule. If the tilt like this, you should now put the CTS here to restore the lens capsule in place. If the tilt like this, now we should put the CTS here. So placing the CTS is very flexible. You can put it anywhere within the lens capsule according to the lens tilt and according to the centration you might face after implanting the CTR. When you put CTR, the IOL better in the bag or in the sulcus? Either way, if you put CTR and the lens now is sorry, the capsule is in place and centered. You can implant a single piece IOL in the bag. You can implant the three-piece IOL in the bag. You can implant the three-piece IOL in the sulcus. So as long as you have stable capsule by the CTR and centered, you can place whatever lens you want in the bag or in the sulcus. So just consider it as a routine surgery. What are the cases of progressive zonulisis? Of course, this is the Marfan syndrome, homocystinuria, vein Marchesani syndrome, microspherophakia, etc. They are a long list of syndromes associated with zonulopathy, and you can suspect zonulopathy if there is a family history of lens subluxation, because sometimes you find a patient comes to you with a lens subluxation and you find his sister or his brother had the same issue, and his mother or his father have same issue or had a past history of complicated cataract surgery because of lens subluxation, even if the systemic manifestation is not apparent. So there are some clues that you can guess this is a progressive zonulopathy. دكتور طارق أبو نصر, thank you very much. دكتور خالد عايش, أهلا. Thank you for the great case number 2, where you have tear in the anterior capsule. Would it possible to fixate the lens to the sclera, for example, while preserving the lens capsule to act as a barrier? Yes, you can fix the IOL to the sclera. Yes, you can just keep the lens capsule in place and fix the IOL to the sclera, and you can keep the capsule as a barrier against CMO. But this patient was an elder patient, and the posterior vitreous detachment was apparent. In this case, this eye has already posterior vitreous detachment, so the incidence of PCO, I think, was low at that time, and because it was a hypermature cataract, I found that already the zonules everywhere was weak. So, and you can see that already I have just removed the lens capsule with ease because already the zonules were weak. So I preferred in this case, because I think the patient was 80 years old and hypermature cataract and complicated by anterior capsular tear. So why to keep the lens capsule? You might keep it because it will help you to support the lens in place while fixating the IOL into the sclera. It may add safety, intraoperative safety for you to fix the IOL and avoid complication of falling the IOL into the posterior segment of the eye. Does ectopic pupil affect your decision? I'm not sure what do you mean by ectopic pupil. It's according to trauma or coloboma of the pupil. Of course, it will affect my decision, but what kind of ectopic pupil? So it depends. If it was trauma, so I will do the same strategy here to keep the lens capsule and try to implant the CTR or CTS and then implant the lens. If it was coloboma, maybe I'll, according to the area of coloboma, so if I can still count on the lens capsule, or just I will remove the lens capsule and now implant the lens fixed to the sclera. So according to the situation. So there is no direct answer for this question. Do you need third hand with you? No, I don't need most of the time. I don't need third hand with you most of the time. Maybe sometimes in cases of glued IOL. Good question. What about Dr. Taqadum? What about the stability of the IOL in cases of posterior fixated iris claw lens? It's pretty well fixed, but I had a couple of cases that came to me with the IOL dislocated in one haptics because of the direct trauma or sometimes spontaneously. So I implanted a lot of these cases in the past few years, but I had only 2 cases of dislocated lenses. And this is one issue that I don't prefer these lenses over the scleral fixation. The other issue that the lens already will have some tunesis because of the tremulous iris, because of the aphakia. Sometimes I need a retinal surgeon, Ahmed. Yes. Do you need retinal surgeon? Yes, I need retinal surgeon sometimes to back me up. A very good question. Do you change the phaco parameters in subluxated cataract? Yes, you can change the phaco parameters in subluxated cataract, reduce the bottle height, reduce the fluidics. I mean by fluidics, the aspiration and the vacuum, and try to work in the anterior chamber. Try to bring the nuclear fragments into the anterior chamber and work slowly. It's called slow motion phaco. And of course, because you are working in the anterior chamber, it's preferred to use a generous amount of dispersive OVD to protect the corneal epithelium. So in cases of subluxed cataract, you can reduce the bottle height to reduce the stress on the zonule and try to have a little bit or relatively stable anterior chamber by reducing the phaco parameters, the fluidics, the vacuum and aspiration rate. And as a technique, you can bring each quadrant outside the lens bag or the lens capsule and try to emulsify it in the supra iris plane or the anterior chamber. So I think we answered most of the questions here. Thank you very much for your attention, and I'm really glad to attend this webinar, and I'm looking forward to have another webinar on the details of the technique of fixing the IOLs to the iris, to the sclera, any other issues that you have faced. So thank you a lot for your attention, and looking forward to see you again in the near future.